My name's Shoaib. I'm one of the co-founders of Bite Medicine, and I will be leading today's session. You may have seen Azim before, and he's somewhere in the chat, and he'll be answering your questions. Good. Just a few housekeeping things. We have a feedback form for you guys to fill out at the end of the session, and if you've participated in 3 or more Bite Medicine webinars, we will be sending you a certificate, so please put down your email on that feedback form. Excellent. Let's get started. Azim is alive, yes. Sorry, I keep getting distracted by the chat. I'm going to try not to do that this time. The quiz is, I don't know if you guys attended our previous quiz, but it's on Mentimeter. It's exactly what we normally do. We will have 14 questions, and you will hopefully get a score at the end of those 14 questions. Some of the questions, you get more points if you answer them quickly. And that you'll know that before you answer the question, it'll tell you that it's a timed question. Some questions are timed, some aren't. So a total of 14 questions, all on endocrinology. If you guys pop onto menti.com, if you could do that now, and we will get started. Question 1. So if you put in that Menti code at the top of the screen, I'll just give you guys some time to do that. There we go, you're all joining in now. I hope you guys have had a lovely afternoon enjoying the weather and are ready for this quiz. There's a mix of some hard questions and some easy questions, so hopefully there's something in there for everyone. Don't worry if you get stuck. We will be going through the explanations and all the answers will be uploaded after. Okie dokie, 250, that's good enough. Let's, I'll give you a few more seconds. Let's get started. Okay, so this isn't timed. You have, you know, the quicker you do this answer, you don't get more points for it. Just take your time. Which of the following is most likely to be raised in acromegaly? Okay, you guys are answering quickly. Procalcitonin, prolactin, IGF-2, LH, and TSH. Good. You guys seem to be answering this pretty quickly, so I'm happy. We would have gone over all of these answers in the previous webinar, so if you tuned in previously, hopefully you will know what you're doing. Oh, very interesting. Okay. Okay, that was a bit of a trick question, to be fair. So let's start off with IGF-2. It's IGF-1 that is raised in acromegaly. IGF-2 is not related to acromegaly. Yeah, I'm sorry about that. Well, it is a top decile quiz, so these questions can be tricky. Prolactin. Now you might be thinking, why on earth is prolactin raised in acromegaly? Surely prolactinoma equals prolactin. Prolactin has nothing to do with acromegaly. But actually, 1/3 of patients, 1/3 of patients with acromegaly also have a raised prolactin. Now, the reason for that, it's not completely well understood, but reading some papers, what it's thought is that the growth hormone secreting cells as part of the pituitary adenoma also secrete prolactin. So not only do they secrete growth hormone, but they also secrete prolactin. And about 30% of patients will have a raised prolactin. Procalcitonin, that's a marker of sepsis. So that's not related to acromegaly. LH and TSH are other pituitary hormones. What tends to happen is if the pituitary adenoma is big, it will squash out the rest of the pituitary and reduce the other pituitary hormones. So growth hormone will be raised, but as the pituitary adenoma grows bigger, it will knock out the other bits of the pituitary. So LH and TSH will be low, they won't be high. Okay, I hope that all makes sense. Sorry, that was a bit of a tricky one to start off with. So we just went over acromegaly, just a brief overview. I mean, I'm sure you guys know this inside out by now, but the hypothalamus secretes growth hormone, releasing hormone, acts on the pituitary releases growth hormone. Growth hormone can act directly on the tissues, and it can also act on the liver to produce IGF-1. Both growth hormone and IGF-1 will have an effect on the tissues to cause growth. I mean, that's what growth hormone does. It will stimulate muscle growth, it will stimulate bone growth, and it will also stimulate the breakdown of fat and glycogen to produce energy for that growth. So this is the hormone axis, just learn it essentially. But the key thing to note here is that dopamine and somatostatin can inhibit the pituitary and inhibit growth hormone release. And that's important because one of the ways we manage acromegaly is by giving dopamine and somatostatin analogs. Good, I hope that's fairly straightforward. Now, this is what I wanted to come on to really, is the investigations for acromegaly. I know a lot of you picked IGF-2 there, but the take-home message from this slide is that the first line investigation in acromegaly is IGF-1, this thing here, insulin-like growth factor 1. This is the first test you'll do to diagnose acromegaly. It's almost like a screening test. If it's raised, you will then go on to do an oral glucose tolerance test. A glucose tolerance test is essentially where you give the patient 75 grams of glucose and then you measure the growth hormone levels. In normal people like you and I, the growth hormone should decrease after having some glucose. In patients with acromegaly, the growth hormone remains high. Once you've done those blood tests and you think the patient has acromegaly, you go on to do a pituitary MRI to actually look at the pituitary and visualize the adenoma. Is that all clear? I mean, hopefully that's fairly straightforward. If anyone has any questions, just drop a message to Azim in the chat. Cool, so yeah, IGF-1, oral glucose tolerance test, and then pituitary MRI. That's a brief overview of acromegaly. Now let us go on to question 2. Patient with galactorrhea has a mass on MRI. Prolactin is raised, but IGF-1 is normal. What is your management? So we have carbergoline, pegvisomant, levodopa, a transsphenoidal resection, and radiotherapy. So these all seem like fairly reasonable answers, but which one is correct? Again, you guys are answering very quickly, so I'm hopeful you'll get this one right. Okay, let's have a look. The answer is carbergoline. Interesting. Okay, so we've got a bit of a split here. Oh, just in favor of transsphenoidal resection. So why isn't it a transsphenoidal resection? I mean, that means basically chopping out the pituitary. Why is that not the answer here? Yeah, so I mean, take it a step back. What's the diagnosis? I guess that's step one. Figure out what diagnosis does the patient have. Prolactinoma. The prolactin is raised, and the IGF-1 is normal. So IGF-1 normal. This is not acromegaly. Raised prolactin, pituitary mass. This is a prolactinoma. Okay. First line management in a prolactinoma is medical therapy. So you give dopamine agonists. The first line treatment in acromegaly is surgery. So get that implanted in your mind, just memorize that. Acromegaly is resection, prolactinoma is medical therapy. I'll come on to why that is in a second when on the slides, but let's just go through these options. So carbergoline is the right answer. That's a dopamine agonist. Dopamine switches off the anterior pituitary, inhibits the anterior pituitary, and therefore reduces prolactin secretion. Pegvisomant is a growth hormone antagonist. It's used in medical treatment of acromegaly, not relevant to prolactinoma. Levodopa is a dopamine agonist, but why is it not used in prolactinoma? I mean, just like carbergoline, it also is a dopamine agonist, but why do we not use it here? Yeah, so side effects is one, and the half-life of levodopa is about an hour, maybe 2 hours. The half-life of carbergoline is a couple of days. So levodopa, you need to give it continuously throughout the day. It has side effects. Patients become tolerant to it. Carbergoline is a much better option in this instance. As I said, transsphenoidal resection, that's first line in acromegaly. And radiotherapy, I think a lot of you clocked on it. This isn't the right answer. You only do that if medical therapy fails or surgical therapy fails. But let's go back to the slides. So we've gone through acromegaly. Now let's look at prolactinomas. Again, this is pretty straightforward. The anterior pituitary releases prolactin. It's stimulated by the hypothalamus, which releases thyrotropin releasing hormone, which acts on the anterior pituitary to then secrete prolactin. The key point that I want you to take away from this slide is dopamine inhibits the pituitary. Just like before with acromegaly, dopamine will reduce prolactin secretion. So that is why we use a dopamine agonist in prolactinomas. So dopamine agonist, here we go, carbergoline is preferred. Now, the question is, so why isn't this first line in acromegaly? Acromegaly is associated with a lot more morbidity and poorer outcomes compared to prolactinoma. If we think about the complications related to acromegaly, patients become diabetic, patients get heart failure, they get cardiomyopathy, they get very, they can have some serious complications from that growth hormone tumor. So you need to get rid of that tumor by resecting it. The outcomes of prolactinoma are not as bad. The morbidity is not as bad. So patients can be managed with medical therapy alone. That's why we don't jump straight to surgery in prolactinoma. The risks of surgery are high, but they are offset by the benefits in acromegaly. The risks of surgery are still high in prolactinoma, but are not offset by the benefits of that surgery. So we just try and avoid surgery where possible in prolactinoma and give them medical therapy instead. So carbergoline is the first line treatment. The take-home point is acromegaly, you treat it with surgery. Prolactinoma, you treat with medical therapy. Cool. Do you guys have any questions? Is there anything that's, that you want me to run through before we move on to the next question? No. Good. Okay. Yeah, bromocriptine. So someone on the chat said, why not bromocriptine? That's an alternative. You can use dopamine agonist. And why stop in pregnancy? Because there's a risk to the fetus. But let's move on. Okie dokie. Oh, interesting question. I like this question. So, a bit weird. Patient comes in the testicular lump. For some reason, he has palpitations. His T4, that's thyroxine, is 27. What is the most likely diagnosis? So we have a seminoma, a yolk sac tumor, choriocarcinoma, Struma ovarii and Graves' disease. So this is yeah, it's an interesting one. There's a lot of words there that some of you may not even come across before, but don't worry about that. We will go through it. Come on, guys. Third one in a row. We need to, next one will do it. Don't worry. Choriocarcinoma. Interesting question. So a patient has a testicular lump. You know, that suggests he may have testicular cancer. There are a number of different types of testicular cancer, and sadly, you just need to learn them. But the key thing here is that choriocarcinoma releases tons and tons of beta HCG. Choriocarcinoma is a type of germ cell tumor, which is a type of testicular cancer, okay? It releases tons of beta HCG. Beta HCG can mimic TSH. It can act on the TSH receptor and cause hyperthyroidism. So take home point from this slide, choriocarcinoma releases beta HCG. That can cause hyperthyroidism. A lot of you went with seminoma, and seminoma, to be fair, is the most common testicular cancer. Seminoma does also release beta HCG, but nowhere near as much as choriocarcinoma. So seminoma is not really associated with hyperthyroidism. Yolk sac tumor is associated with testicular cancer in young children. Graves' disease, Graves' disease is not related to this. The patient has hyperthyroidism because of their testicular cancer, okay? Struma ovarii is found in women. So, I mean, this is a man with a testicular lump, so it can't be struma ovarii. But just for those of you who are interested, struma ovarii is a teratoma found in women, which can cause hyperthyroidism. But this is a man, so it's not that. Okay, and let's have a look at the slides. We will go over hyperthyroidism very briefly. So hypothalamus releases the thyroid releasing hormone, which then causes the anterior pituitary to release TSH. And I'm sure you guys know this kind of off the back of your hand, but the thyroid gland then releases T4 and T3. T4 is, so T3 is the active form and T4 is less active. Most of the hormone released by the thyroid gland is T4. It then goes off into the peripheries and is converted to the active form of T3. And then that goes and exerts its action on the cells. But the key point that I wanted to go over is the causes of hyperthyroidism. So we have primary hyperthyroidism and secondary hyperthyroidism. Primary occurs when there's a problem with the thyroid gland, and the most common causes are Graves' disease and toxic multinodular goiter. Graves' disease, is where you have anti-TSH receptor antibodies, which then stimulate the thyroid gland, and these patients therefore become hyperthyroid. Toxic multinodular goiter is a bit more confusing because it's caused by iodine deficiency. So a lot of people think, well, if a patient's got iodine deficiency, how on earth can they have hyperthyroidism? The explanation is iodine deficiency causes a compensatory increase in TSH. You then get hyperplasia and goiter formation, and the goiter is often nodular. So you get a nodular goiter. Over time, you get a few mutations accumulating in the nodules, and they can become independent of TSH. So they start releasing tons of thyroid hormone independently of TSH. And that's the pathophysiology behind a toxic multinodular goiter. If we just go on to the next slide. And this is the slide that I really wanted to focus on, is secondary hyperthyroidism. So these are causes which are due to either pituitary or hypothalamus pathology, or basically causes outside of the thyroid gland. So you have a pituitary adenoma, that's very rare. To have a TSH secreting pituitary adenoma, that's extremely rare. To have all of these are very rare actually. Again, to have a tumor in the hypothalamus is extremely rare. The one that the question asked about was this HCG secreting tumor. So as I said, some patients can have a choriocarcinoma. That's a germ cell tumor, and it can manifest as either a testicular tumor or ovarian cancer. They secrete tons and tons of HCG. The HCG mimics TSH and will therefore cause hyperthyroidism. The other one is a struma ovarii, which is a teratoma which just secretes thyroxine, okay? So it's, instead of secreting HCG, it secretes thyroxine, and that's found in women. Before I move on, does anyone have any questions in the chat that they'd like me to address before moving forward? I thought HCG was only produced by pregnant women. No, it's also produced in these tumors. Can men get teratomas? Yes, they can. So one cause of testicular cancer, one form of testicular cancer is a teratoma. There's lots of different forms of testicular cancers, and sadly, you just need to memorize them. But one of them is a teratoma. Okay, let's move forward. Next question. I'm confident you guys are going to get this one. Okay, which of the following antibodies is most likely to be found in Graves' disease? So, okay, we have anti-TRH, anti-thyroglobulin, anti-nuclear antibody, anti-mitochondrial antibody, and anti-microsomal antibody. So which of those is most likely? This is a bit of a tricky one, actually. Sorry, so this is a top decile quiz. These questions are hard on purpose. There are a few more easier ones coming up, I hope. You have 3 seconds. I have faith. Oh good. Wow, what I wonder who that one person was. Well done. I mean, you did excellently well. It's an anti-microsomal antibody. Gosh, I feel bad now. I probably should have made these a bit easier. But okay, what is anti-microsomal antibody? You may be asking, and that's a very good question. Anti-microsomal is the same as anti-thyroid peroxidase. Okay, it's another name for anti-thyroid peroxidase antibody. I will go through a table which contains all the antibodies in just a second, so don't worry, we will go through that. Let's go through all of these in turn. Anti-mitochondrial, what disease do you find anti-mitochondrial antibodies in? PBC. So for those of you who don't know what PBC is, primary biliary cirrhosis or primary biliary cholangitis, depending on what you read. It's the same disease. You get anti-mitochondrial antibodies. Anti-nuclear antibodies, you mainly find those in things like rheumatoid arthritis, lupus, Sjogren's syndrome, you know, the rheumatological conditions. Anti-TRH, no, it's anti-TSH, okay, so that's wrong. Anti-thyroglobulin is correct, but you are much more likely to find anti-thyroid peroxidase, i.e. anti-microsomal antibodies, than you are anti-thyroid globulin in Graves' disease. Just to clarify, I know some of you might be thinking, well, anti-thyroid peroxidase equals Hashimoto's. It's not, yeah, that is true, but let me just show you this table. Okay, so this is a really nice table, actually. It's the different autoantibodies you get in each of Graves' and Hashimoto's. The point being, you get both anti-TSH and anti-thyroid peroxidase in Graves' disease. okay? But in Graves' disease, you get almost all patients have anti-TSH, but about 70% of patients will have anti-thyroid peroxidase. In Hashimoto's, almost all patients will have anti-thyroid peroxidase, and they won't have anti-TSH. Just to clarify, anti-thyroid peroxidase is exactly the same as antimicrosomal. It's just a different name for the same thing. So well done to that one person who got it right. You know, yeah, 1 out of about 350, well done. Antithyroid globulin, you find it, you do get it in Graves' disease, but its prevalence is much lower compared to anti-TPO and anti-TSH. You just learn this table and you'll be fine. Yeah, I know that was a hard question, but you know, life's hard, so let's move on. Yeah, so it will always be called anti-TPO in your exams, probably. Well, that was just me trying to be difficult. Okay, a G3P2 lady presents in the 11th week of gestation. She's on propyl thiouracil for Graves' disease. Which of the following is true? G3P2, for those of you who don't know, if that's just kind of nonsense to you, G3 means she's had 3 pregnancies and P2 means she's had 2 babies. So what are we going to do with her thyroid medication? She's pregnant, she's got Graves. What should we do? Okay. Oh, okay, interesting. I mean, this is a hard question, but one that could definitely come up in your exams. They like testing what to do with thyroid disease and pregnancy. I guess it's quite a common thing you'd see in practice as well. So, okay, let's go with the most common answer. Continue propyl thiouracil. So, NICE guidance says, if a patient is pregnant with Graves' disease, you switch them to propyl thiouracil for the first trimester. Once the first trimester has finished, you must switch them back to carbimazole, okay? Propyl thiouracil is teratogenic, which means it can harm the fetus in the first trimester. After that, you switch it back to carbimazole. Does anyone know why you switch back to carbimazole? Why would you switch from propyl thiouracil to carbimazole? There is a very specific reason. Yeah, so whoever hepatotoxic. Propyl thiouracil, according to NICE, in the 2nd and 3rd trimesters has been shown to be hepatotoxic, which means it damages the liver. So you switch to carbimazole, which is less likely to damage the liver. The first thing about the first trimester is the first 12 weeks or so. That's when the main processes of forming the embryo and the fetus are happening. And that's when propyl thiouracil is safe and carbimazole is dangerous. After the first trimester, you can use carbimazole. I hope that's clear. You don't need levothyroxine, and you don't increase the dose because you're switching it to carbimazole. And you can't switch to carbimazole immediately because she's still in the first trimester. Let's go back to the PowerPoint. So don't worry if you didn't get all of that, it should be listed here. Essentially, Graves' disease, you need to treat the hyperthyroidism. The way you do that is you give an anti-thyroid drug. So you can either give carbimazole or propyl thiouracil. Carbimazole is first line, and propyl thiouracil is first line in pregnancy, or if a woman is planning on becoming pregnant. So even in the build up to their pregnancy, you should start them on propyl thiouracil. You only use it in the first trimester, and then you switch back to carbimazole because propyl thiouracil is hepatotoxic. that's the key take-home message from this slide. I mean, we went over this all in this other stuff in the hypothyroidism lecture, but just in brief, there's two different ways which you can give these medications. You can either give a high dose and then titrate it down until your TSH normalizes, or you can give a high dose and replace your levothyroxine as needed. What normally happens is patients are started on antithyroid medication, and then if that works, that's great. But if that fails, they tend to have definitive radioiodine or surgical treatment for their Graves' disease. So just to clarify, carbimazole is first line. You switch it to propylthiouracil if women are planning pregnancy or they are pregnant in the first trimester, because carbimazole is teratogenic. It will damage the fetus. And then you switch it back in the second trimester. Does anyone have any questions? Why would you increase the dose in pregnancy? No, you wouldn't. Not of antithyroid drugs. Why don't you keep her on propylthiouracil? Because it's hepatotoxic. So you need to switch after the first trimester. Okay, let's move on. Next question. No, sorry, propylthiouracil is hepatotoxic to the lady, not to the fetus. Okay. Great, so a patient is on levothyroxine. For some, I mean, let's assume they've got iron deficiency anemia. So, okay, it says that there, sorry. So they're starting on ferrous sulfate. What advice do you need to give them? Hard question, but could definitely come up in your exams, and it's important to know this. So patients on two medications, levothyroxine and ferrous sulfate, what do they need to know? It's 5 seconds remaining. Sorry, I know these questions are a bit difficult, but they're there to challenge you. Okay, good. So you guys got this one right. Excellent. You take the medications 4 hours apart. Why? Because iron inhibits absorption of levothyroxine. This is common. You'll see this in clinical practice because lots of patients who have hyperthyroidism may well have iron deficiency anemia. And if they're on oral iron supplementation, they must be told to take the medications 2 to 4 hours apart at least, because, as I said, iron will reduce levothyroxine absorption. Now let's look at the other options. Increase the dose of levothyroxine. No, you just tell them to take them at separate times of day. There is an increased risk of GI bleed. Nope. Take the iron 30 minutes before food. I mean, you tend to take iron after food, but that may be some advice that would be given. But the key thing is you need to take the medications apart, okay? Because even if you take the iron 30 minutes before food, but you take it with levothyroxine, you're going to cause problems because the levothyroxine won't be absorbed. You don't take the medications at the same time for reasons we've discussed. Okay. All right, on to another question. Let's get back. So, a patient has the following: TSH of 11, a T4 of 10. What is your next step? So think about what area is this testing you on? What is the diagnosis? And then figure out what the answer is. Okie dokie. Again, this is one which could come up in your exams. I don't really know what to say in this 45-second interval, but I hope you've all had a lovely day, had something to eat, and are refreshed. Your brain is ready for the next 7 questions. Look. Ooh. Repeat TSH in 3 months. Well done to the 39 of you that got that right. So NICE is a bit weird on this. They say that if, okay, first of all, forget what NICE say. What's the diagnosis? What diagnosis does this patient have? Yeah, that's the key thing. So I think you all nailed that bit. So well done. It's subclinical hypothyroidism. Now, you don't manage subclinical hypothyroidism the same way as you manage normal, what's called overt hypothyroidism. NICE say that if the TSH is raised, but the T4 is normal, that's the definition of subclinical hypothyroidism. Okay, we'll come on to this in a slide, but essentially, normal thyroxine, but raised TSH equals subclinical hypothyroidism. NICE says you must repeat the TSH in 3 months. It doesn't matter if they're symptomatic or asymptomatic. You need 2 accurate repeat samples over the space of 3 months before starting any treatment, okay? So that's why all of these other answers are wrong. You don't commence levothyroxine. You don't commence levothyroxine if they're symptomatic. That might sound odd, and in reality, if they are significantly symptomatic, you may well just start. But NICE say, technically, you should have 2 separate results separated by 3 months. Okay. Now, let's have a look at the guidance. We will go over this because this is a bit confusing. So we know this thyroid axis, we've gone over that, but what I want to point out is this table here. You can think of thyroid disease as a spectrum ranging from normal. So on one end of the spectrum, you have normal thyroid function. At the other end, you have overt hypothyroidism, where you have a raised TSH and a low thyroxine, okay? Somewhere in between that spectrum, you have subclinical hypothyroidism. So these patients haven't quite reached the stage of hypothyroidism yet, where their T4 is low, but they're getting there and they're almost on their way to becoming hypothyroid properly. So their TSH is raised, but their thyroxine is actually normal. So this is all referring to primary, by the way. This is all referring to primary hypothyroidism. So overt is where T4 is low, TSH is raised. We know that. But subclinical is where your T4 is normal and your TSH is raised. NICE has very specific guidance on what to do in these patients. Overt hypothyroidism. So these are 2 forms of primary hypothyroidism, overt and subclinical. In overt, we know you give patients levothyroxine. They need their thyroid hormone replaced. In pregnancy, you increase the dose. So a few of you earlier were asking, do you increase the dose of, I think it was carbimazole or something in pregnancy? You don't increase the dose of anti-thyroid drugs. You increase the dose of thyroxine, okay? That's because the metabolic demands during pregnancy increase. Therefore, your requirement for thyroid hormone increases. Therefore, you must increase levothyroxine during pregnancy. In ischemic heart disease, you reduce the dose because thyroxine is, you can think of it as a stimulant. It increases cardiac output and heart rate. Therefore, if you give the patients too much thyroxine, it will put too much strain on the heart. So you must reduce the dose. Iron supplementation, we've gone over. It reduces absorption, so you take them a couple of hours apart. Subclinical hypothyroidism. So this is directly taken from NICE, okay, in the most recent guidelines. It says the below must be measured on 2 separate occasions, 3 months apart. And if they are measured on 2 separate occasions, 3 months apart, and your TSH is above 10 with the normal T4, then you consider levothyroxine. If it's less than 10 on 2 occasions, and they are symptomatic, and they are fairly young, less than 65, then you can consider levothyroxine. It's a bit confusing and it's not really intuitive, that, but just break it down. TSH raised greater than 10 on 2 occasions. It doesn't matter if you're symptomatic or asymptomatic. If your TSH is above 10 on 2 occasions, NICE say start treatment. If your TSH is less than 10 on 2 occasions, only start treatment if you're symptomatic and you're young. Otherwise, don't start treatment. Does that make sense? Does anyone have any questions on that? What is the reason for the less than 65? Because you don't want to jump in treating elderly patients with levothyroxine because they may have other comorbidities such as ischemic heart disease, which the levothyroxine will then make worse. Does this happen in practice? This is NICE guidelines, so this is what you need to know for your exams. And it probably does happen in practice to a good degree. If patients come in, I reckon, in reality with a TSH above 10 and they're very symptomatic, you probably would just start treatment, even if you don't have two samples. But this is what NICE says, so this is what you need to know. Okay, let's move on. Oh yeah, sorry, this is a leaderboard to see where you're at. So we're halfway through. Anna 3 is leading the race, and I think that's the top 10. So Anna 3, Marshmallow, Millie, all you guys are doing really well. Everyone's doing well. Keep it up. Yeah, Anna 3, take a bow. Okay, this is timed. You need to do this quickly. The quicker you answer, the more points you get for this question. A 17-year-old with polydipsia and weight loss. You're seeing this 17-year-old as a doctor. His random glucose is 14 and his BMI is 28. What is first line? I know a few of you have some questions on the subclinical hypothyroidism, so I'll come back to it. I will come back to it at the end of the lecture to go over it again. Oh, well done. Okay, good. So it's a young guy who's got symptoms of diabetes. He's got his random glucose is raised, it's 14. The cutoff is 11, so he's well above that. His BMI is 28 is irrelevant. A young patient with BMI of 28, that's only marginally raised, okay? He's only slightly overweight. So this is not type 2 diabetes, this is type 1 diabetes. So metformin is wrong because that's what you do for type 2 diabetes. This is type 1. How do you manage type 1? You give a long-acting insulin plus a rapid-acting insulin before meals. So that's Levomir and Novorapid. Levomir, according to NICE, is first-line long-acting insulin. Lantus is second-line long-acting insulin. Obviously, you don't give two long-acting agents together, which is why Lantus and Levomir is wrong. And Humalog mix 50 is intermediate mixed insulin. I'll go on to what the different types of insulins are in the PowerPoint. So some people are asking, how do you know this is type 1 versus type 2? Well, is a BMI of 28 in a 17-year-old, think of all the 17-year-olds, you know, who have a BMI of 28 and do they have type 2 diabetes? It's not, a BMI of 28 is not a big risk factor for type 2 diabetes in a 17-year-old. If this was a 60-year-old who had a BMI of 28, then that would be type 2 diabetes. He's young. 90% of patients with type 2 diabetes, or a massive proportion of type 2 diabetics, are not teenagers. Teenagers very rarely develop type 2 diabetes. It is becoming more common because of our diets and the way we live. But in a 17-year-old with symptoms, with a slightly raised BMI. This is type 1 diabetes until proven otherwise. Okay. I feel like we need more information, some of you are saying. Yeah, you're right. In real life, you would have more information, but in exams, they purposely leave out information to try and make it a bit tricky. So I'm sorry, but you're right. You should have more information, but I'm just trying to make it a bit like your exams. So how do you manage type 1 diabetes? You refer them to a diabetes team, obviously, but after that, lifestyle is very important. You need to educate them regarding their diet, not to have too much sugars and fats. But this is the key point, insulin therapy. The first line insulin regime, according to NICE, is a basal bolus regime. Now, what on earth is a basal bolus regime? So these patients are given a long-acting agent, and that acts throughout the day. It's usually given once in the morning and once in the evening. And they are also given a rapid-acting agent before meals. So the long-acting agent is the basal, the rapid-acting agent is the bolus. So the basal, first-line basal therapy is with Levomir, and Lantus is second line according to NICE. Bolus is usually Novorapid, and that's given before meals. And some of you might be thinking, you know, these are brand names. So in diabetes, you always use brand names, okay? You don't use the generic Detamir, Glargine, etc. You must use the brand names to prescribe in clinical practice, and that's what's advised, okay? So sadly, you need to learn the brand names. I wouldn't worry too much about learning the actual biological names like Detamir and Glargine, because it's the brand names which you'll use when you're a doctor. Basal bolus is first line, but the problem is you can imagine you having to have an injection in the morning and possibly in the evening as well, and 3 injections, 1 before every meal. So that's 4 or 5 injections every day, and patients don't tend to like that. So NICE say that if they don't tolerate 4 or 5 injections a day, you can use a mixed insulin regime. And that's just 2 injections every day, and it consists of a short or a rapid acting mixed in with an intermediate acting insulin. So it's all of those mixed in one, and you give it in the morning and the evening. Continuous insulin infusion, that's a bit niche. That's used third line in patients who don't get on too well with their insulin therapy, or they have really bad hypoglycemic episodes. This is really the slide that I wanted to show you guys though, because you need to know what the difference between the different types of insulins are. You have rapid, short, intermediate, long, and it's obviously fairly self-explanatory that rapid is the quickest acting and long is the longest acting. And you can sort of learn these time frames, but the key thing from this slide is to just learn 1 or 2 examples of each category. So rapid, make sure you know that Novorapid is rapid. Make sure you know Act Rapid is short. Humulin I and Insulatard. So Humulin I for intermediate, Insulatard begins with an I for intermediate, okay? And Levomir and Lantus both begin with an L for long acting. Humulin S has an S in it for short acting. That's one way to remember it. But I would learn 2 examples of each because this is something they may well test you on in your exams. Okay, does anyone have any questions before we move on to the next part? So yeah, so long acting, if you just go back to that slide, so this just gives you durations. Long acting takes about 2 to 4 hours to start working and acts over about 1 to 2 days. Levomir, yeah, Levomir is BD. So you give Levomir BD and that's first line, but Lantus is once daily. Levomir is twice daily, Lantus is once daily. Okay. How many times do you give Novorapid? You give it before every meal, so 3 times if they eat 3 times a day. We have a 21-year-old gentleman who presents with abdominal pain. His VBG shows a pH of 7.1 and a glucose of 28. So that's urinary ketones. His urinary ketones are 2+ with a blood pressure of 99/69. So imagine you're seeing this gentleman in the emergency department, very common. What are you going to do? What's your first line management? So we have different fluid regimes and a fixed rate insulin infusion. Good. So this patient has DKA, diabetic ketoacidosis, okay? He meets all the criteria. He's acidotic, he's hyperglycemic, and he's ketotic, okay? His ketones are raised, his sugar is raised, and his pH is low. This is concerning DKA kills, and this is something you will commonly see when you are doing your A&E rotations and when you are emergency medicine doctors in your FY rotations. The first line therapy for DKA is 1 liter saline over 1 hour. Now, if we take all of these samples by, all of these answers by turn, why do you not give a stat bolus? You only give a stat bolus if the patient is hypotensive. And by hypotensive, the blood pressure must be less than 90 systolic, okay? The reason we avoid stat boluses where possible in DKA is because you don't want to drop the sugar too quickly. If you start dropping the sugar quickly, that can cause cerebral problems. So they can develop cerebral edema and central pontine myelinolysis. So try and drop the sugar slowly. You give 1,000 mils of sodium chloride over 1 hour, that's first line, and that will reduce the patient's glucose. Even though they're not having insulin, saline fluids does reduce patients' glucose levels. Again, we avoid stat boluses. Why don't we add in potassium chloride? The first bag of fluids in DKA, you do not put any potassium in. It's the second bag of fluids that you put the potassium in. The reason for that is it takes time to measure what the potassium is. So patient with DKA comes in, you hook them up to fluids, you take their bloods, you wait an hour for the potassium to come back from the lab, and then based on the potassium results, you will give them an appropriate amount of potassium chloride. You do not start fixed rate insulin infusion before fluids. Fluids is always first line, okay? Let's just go through this on the slides. So these are criteria according to the Joint British Diabetes Society, okay, for DKA. So if a patient is hyperglycemic, acidotic, and ketotic, that is DKA. But just going into it in a bit more detail, you can have a raised glucose or known diabetes, plus a low bicarb and or low pH, and one of these two to signify raised ketones. The patient must meet each of these criteria in the 3 boxes, okay? But the take-home message is DKA is hyperglycemia, acidosis, and ketosis or ketonemia. If you hit all of those 3, then the patient has DKA. Okay, so this is DKA management. Remember, so if the patient is in shock, i.e. their blood pressure is less than 90, then you can give a stat bolus of fluids, 1 liter over 15 minutes, and these patients will need ITU. This is a bad sign if they're hypotensive. It means they're losing so much fluid from all their vomiting and insensible loss through their DKA that they're going to need very careful monitored fluid replacement, so they will need ITU, and this is worrying. Most patients will have a normalish blood pressure above 90. First line is, first bag, you give a liter of sodium chloride over 1 hour. In the next bags of fluids, you add potassium, okay? Now, some of you might be thinking, if you weren't here in our lecture on diabetes, why on earth do you need potassium? Patients with DKA have total potassium, which is low. Their total body potassium is low because they're vomiting all of their potassium out. Also, yeah, they have a lot of insensible loss through which they lose their potassium. And when you start insulin, the insulin is going to push all of the potassium into the cells. So insulin pushes potassium into cells. That will further decrease the patient's potassium levels. So patients must commence potassium replacement after the first bag of fluids. And how do you replace potassium? It depends on their serum concentration. And this is why you wait. You give the first bag, you take the patient's UNEs, you measure their potassium, that takes about an hour. Once you have the potassium level back, then you can start replacing potassium according to what their serum concentration is. So if it's raised, you don't give any potassium replacement. And although, just to clarify this, although their serum potassium might be raised, their total body potassium is still low, okay, from all the vomiting, etc. But some patients can still have a raised serum potassium. So serum potassium is different from total body potassium. Total body potassium includes the potassium inside your cells. And if you remember back to sort of year 1 physiology, most of potassium lives inside cells. But regardless, if the potassium on the serum is raised, you don't give any replacement. If it's between 3.5 and 5.5, you give 40 millimoles per liter. And if it's lower than that, you need to call ITU because they're going to need rapid potassium replacement. Okay. So I hope that's clear. Give fluids, give potassium after the first bag, and start a fixed rate insulin infusion. Before we move on, does anyone have any questions regarding that? Happy. Yeah, so Azim said you can get potassium off of VBG. That's true as well. You can get a potassium level off of VBG, but it's often not as accurate as a serum level, which is sent to the lab. So someone's asked, if the serum potassium is high, but their total body potassium is low, you still don't give potassium. So that's correct. Every patient with DKA will pretty much have a low total body potassium. Their serum potassium may be raised. If the serum potassium is raised, you still don't give potassium replacement because there's a risk that you're going to raise their serum potassium concentration too high and cause a fatal arrhythmia. So you don't give it if the potassium on the serum is raised. Okay. Yeah, so exactly. Have a look back at our DKA lecture, which goes over everything. Question 10. All right. So type 2 diabetic is planning on becoming pregnant. She's on a glycoside and has good glucose control. What would you guys advise? So we can either continue the glycoside, we can switch to a glitazone, switch to a gliptin, switch to an insulin, or we add in metformin. It's a bit tricky, this one, actually. So it's about knowing what agents and how diabetes is managed in pregnancy. So again, this is very important because you'll see pregnant diabetic ladies a lot in clinical practice. Okay, so let's go with continued glycoside first. The reason this is wrong is glycoside is not used in pregnancy. There are only 2 diabetic agents which can be used in pregnancy, and that's insulin and metformin. Those are the only two things which are considered safe in pregnancy. All the other agents are either not well tested or are known to be teratogenic, i.e. they damage the fetus. So if a patient is coming into you on a gliclazide and she wants to become pregnant, or she is pregnant, you need to switch her over to either an insulin or metformin. So adding in metformin is wrong because she would still be on the gliclazide. You either switch to insulin or you switch to metformin. Again, as I said, gliptin and glitazones, they're not proven to be safe in pregnancy. Fine. So let us just have a look at the slides quickly. Oh, sorry, we've got another question. So you have a type 2 diabetic on 1 gram twice a day of metformin, and her HbA1c is 55 millimoles per mole. Her BMI is 31, her EGFR is 62. What is the next best step? Just to let you guys know, a normal EGFR is above 90. Okay. So what is your next step? Are you going to increase metformin or start her on an alternative, add in an alternative anti-diabetic medication? How many questions left? There's another 3 questions. Okie dokie, let's see. What do you guys think? Okay, so this is another difficult question, to be fair. But this is actually a really common question in exams. They love testing like diabetes medications and when to use each one. So most of you went with gliclazide, but gliclazide causes weight gain. She's already got a BMI of 31, so you probably don't want to give her a gliclazide. You can't increase the metformin dose. She's already at maximal dose. 1 gram BED is maximum, so there's no scope for increasing. Why can't we use pioglitazone? Pioglitazone causes weight gain. Why can't we start liraglutide? Liraglutide is only used in patients with a BMI of above 35 who have failed on 3 separate diabetic medications. We'll go through this in a second. So that only leaves this thing, dapagliflozin. This does not cause weight gain. And this is perfectly acceptable to use in this instance. Okay, the EGFR here is actually fairly decent, and all of these medications can be used with an EGFR in the 60s. Some people are saying, well, the HbA1c is 55, so that's not too bad. Okay, let's have a look. Oops. Okay, so first line treatment in diabetes is lifestyle. Then you step up to metformin, okay? So a lot of you are saying the HbA1c step up is 58, and that's right. You are correct, it's 58. So in reality, the option there would be to intensify lifestyle measures and educate the patient. But that was not an option that you were given, okay? So in the most correct answer is, you know, get the patient into clinic and educate them about lifestyle measures and what they need to be doing. But exams are asking you for the single best answer. So in that instance, if a patient comes in with fairly poor glucose control and they are on an agent and they're overweight, what's the next best agent we're going to use? The next best agent would be an SGLT2 inhibitor, as that does not cause weight gain. Sulfonylurea causes weight gain. Pioglitazone causes weight gain. DPP4 inhibitor would also have been acceptable, but that was not, I'm not sure if that was given as an option. So that's, sorry, this is going through the mechanisms of action. I don't really want to touch on that right now, but that is in our diabetes lecture previously. this is what I want to go over is the side effects. So big guanides are things like metformin, and they most commonly cause an upset gastrointestinal system. Patients have nausea, vomiting, they can get AKI. So patients who have an EGFR of less than 30, you must stop metformin. If the EGFR is less than 30, you must stop metformin. Sulfonylureas cause hypoglycemia and weight gain. The patient had a BMI of 31. That's why you don't give a sulfonylurea. This thing, I can never pronounce it, but it's the glitazones. That causes weight gain. So that's why we couldn't give it in that instance. And that only left us with an SGLT2 inhibitor. The side effects of SGLT2 inhibitors is that they cause a UTI. They can cause recurrent UTIs because the way they work is through excreting glucose in the urine. Therefore, if you have high glucose in the urine, you are more susceptible to UTIs. And then these two drugs are actually pretty well tolerated. They don't have significant side effects other than a bit of GI upset. Okay. Let's go through the last few questions. So which of the following is true regarding the monitoring of patients with diabetes? We should check the HbA1c annually. Patients should self-monitor. The EGFR should be monitored annually. Eye screening 6 monthly or foot screening 6 monthly. So just reading through some of the comments, is there a link to these slides? We will release them after the lecture. The reason we didn't release them before is because it would have given away all the answers, but we will certainly release them. Okay, let's see what you guys think. Good. Yes, very good. So this is in all diabetic patients, whether it's type 1 or type 2, HbA1c is checked 3 to 6 monthly. Patients with type 2 diabetes do not monitor their own glucose. They only monitor their own glucose if they are on insulin, okay? Otherwise, they do not monitor themselves. Eye screening and foot screening are conducted upon diagnosis and thereafter every 12 months, so annually. EGFR should also be monitored annually. Okay. So just, this again was in our previous lecture, but just to touch on it is exactly what I said just then. The key thing is monitor your HbA1c every 3 to 6 months. Foot and eye screening should be conducted on diagnosis and thereafter every 12 months. Of course, if they start to develop symptoms like visual deterioration or ulceration of the feet, you must re-refer them urgently. And you must also measure their EGFR and their urinary albumin creatinine ratio every 12 months. And that's because patients are, of course, at risk of diabetic nephropathy and CKD. Let's have a look at the next question. So these are the last two questions, guys. I can see a few questions in the chat. I'll get to them in a second. So we have a Cushing's disease, possible Cushing's disease patient here. What is your first line investigation? We have 24-hour urinary cortisol, a random cortisol, ACTH, high-dose dexamethasone suppression test, or an MRI of the pituitary. So just in these few seconds, I can see a few questions. I think Azim's answered that. Yeah, albumin creatinine is more accurate than protein creatinine ratio. And yeah, that's pretty much answered the question. Okay, you didn't fall for the trap. which is quite annoying. You all got it right, good. Cushing's disease means a pituitary adenoma, okay? A pituitary adenoma which secretes cortisol and therefore causes Cushing's syndrome. So Cushing's disease is a cause of Cushing's syndrome. But of course, clinically, you may have a suspicion, but you first need to measure the cortisol levels. You can't jump to doing an MRI pituitary straight away, which is the trap in this question. First, you need to confirm high levels of cortisol. The way you do that is with a urinary cortisol. You do not measure random cortisols because of circadian variation. Cortisol varies throughout the day. A one-off random sample is not enough. ACTH will not tell you the levels of cortisol. It will tell you the levels of ACTH, so that's not helpful at this stage. And a high-dose dexamethasone suppression test, I'm not going to go into this in too much detail because we covered it in depth in the last lecture, but that's not used to diagnose Cushing syndrome. That's used to differentiate between a pituitary adenoma and an ectopic source of ACTH. The first step is you need to confirm high cortisol levels, which is with this urinary cortisol level here. Let's just go over that. So again, step one, you need to confirm high levels of cortisol, as that's what Cushing's is. A few of you are asking, what's Cushing's disease and Cushing's syndrome? So Cushing's disease is a pituitary tumor which secretes ACTH and therefore increases cortisol levels. Cushing's disease is a cause of Cushing's syndrome. Okay, just think of it as a pituitary adenoma. Step one, confirm hypercortisolism. You can do that through any one of these four measures: 24-hour urinary free cortisol, late night salivary cortisol, so you take regular saliva samples and measure cortisol, or an overnight or a low dose dexamethasone suppression test. So dexamethasone suppression test, I'll quickly go over this, but you give some you give some dexamethasone that inhibits the anterior pituitary and therefore switches off cortisol production. That's what happens normally in patients with any cause of Cushing syndrome. Because they're producing so much cortisol, dexamethasone is unable to inhibit the pituitary enough. You still have lots of cortisol being produced and you do not get suppression of cortisol. But go through it in the previous lecture. We went into it in quite a lot of detail there. So once you've confirmed high levels of cortisol, the next step is you need to think about where is the cortisol coming from. And that leads me onto this diagram here. So you've confirmed high levels of cortisol. The next thing you do is you measure an ACTH. If the ACTH is low, that means the cortisol is coming from the adrenals and they are suppressing the pituitary and ACTH release. So if ACTH is low, you scan the adrenals. If ACTH is high, it must be coming from either the pituitary gland or a cancer somewhere in the body which is secreting ACTH. That's called an ectopic source. So if the ACTH is raised, it's either coming from the pituitary or an ectopic source. To differentiate between an ectopic and a pituitary tumor, you carry out a high-dose dexamethasone suppression test. With a pituitary tumor, cortisol levels will be suppressed and you conduct an MRI scan of the pituitary. With an ectopic source, cortisol levels will not be suppressed, and then you do a full body scan to look for the ectopic cancer. Okay. And this is just a summary. So in a pituitary tumor, for both low dose and high dose, you will have suppression. For an ectopic source, you will only have suppression in a low dose dexamethasone suppression test. Again, I know that's a lot of information at once, but if you look back at our last lecture on Cushing syndrome, it goes into things in a lot more detail. Okay. So, well done, McBeardy face. Oh, what's going on here? Oh no, Christina. Christina, well done. You don't get a prize, but really well done. You've done amazingly well to get through some of those questions. They were really tough. Don't worry if you found that difficult. That was meant to be difficult. But before you all head off, could you please fill out the feedback forms, which Azim should post in the group somewhere. And if you've attended 3 or more webinars, we will get you a certificate. If you have any questions regarding this lecture specifically, you can post them in the chat and I'll try and get to your questions. Someone said, why did I violate you with these questions? I'm sorry, that wasn't my intention, I promise. But now you've come through this, you can come through this as a new man or woman. You're ready for the exams now. Azim is there posting away the feedback forms. Please fill those out. Like us on Instagram, or follow us on Instagram rather. Go to our Facebook group, follow us on there. We are in the process of officially launching our website this week, but if you check us out at bitemedicine.com, the platform of questions and textbook is live. We have an online textbook and loads of cases. Go check it out. We have a few things planned for you guys. We're releasing a blog tomorrow. Stay tuned.